A very warm and happy afternoon to one and all. On behalf of GarbhaGudi and GGIRHR, I welcome all the doctors to today's CME on Infertility 2020. GarbhaGudi is a chain of new generation infertility treatment hospitals equipped with state-of-the-art infrastructure and cutting-edge technology. It was founded by a team of committed entrepreneurs and healthcare specialists led by Dr. Asha S. Vijay. GarbhaGudi Institute of Reproductive Health and Research, GGIRHR, is a sister organization of GarbhaGudi and is today known as one of the India's premier infertility training organization. GGIRHR was started in the year 2018 and Dr. Asha S. Vijay is its Dean and Scientific Director. GGIRHR intends to create a revolution in training doctors and embryologists in the field of fertility. Students at GGIRHR can learn tips, tricks, processes, protocols, and treatment approaches followed at GarbhaGudi IVF, which has given such unbelievable success rates consistently. Dear participants, I request you all to post your queries and feedback in the chat box. We will address them at the end during the question and answer session. I also request all of you to keep your videos off and microphones on mute. For the first session, I would like to welcome Dr. Asha S. Vijay. Dr. Asha S. Vijay is a well-known fertility specialist and leading name in the field of fertility and reproductive treatment. She is also a specialist in obstetric gynecology and obstetric sonology. She is graduated in medicine from prestigious Bangalore Medical College and did her post-graduation in OBG from the same institution. She founded GarbhaGudi IVF Centre, a chain of IVF centers in Bangalore known for its extraordinary success rates, ethical treatment, and humane touch. She currently is the medical director of GarbhaGudi IVF Centre. She is also the founder, dean, and scientific director of GGIRHR, a premier reproductive health training organization. She is very passionate about conducting educational programs for gynecologists to help them improve their fertility outcomes. She is also an active participant and sponsor of multiple research papers in the field of infertility. Welcome, Dr. Asha S. Vijay. Over to you.
Thank you, Ulfat, for those very nice appreciative words. Thank you so much. Happy evening, everybody. This CME will be one of its kind in educating the gynecologists who are really interested in having their infertility practice and are having very good success rates. And you will become aware of all the protocols of GarbhaGudi and you will experience the amazing success rates of GarbhaGudi, the technologies used, and all the protocols used by our doctors. So today being the first session, we'll have a bird's eye view, how to go about with the protocols of infertile lady, how to evaluate her, how to do the proper workup, select the best treatment, and how to come to a common conclusion so that she has the best success rates. So this lady, this is a real life story. I saw her around 10 years back. She was around 25-year-old, married life of 7 years. She had already undergone 6 ovulation induction and timed intercourse cycles. The previous consultants had given her 50 mg to 100 mg clomiphene citrate. She had ovulated too, but she had not conceived. So as the mind of the patient, when they're not having success with one consultant, they usually change the doctor and go to a second consultant so that they can have a good success rate. That consultant, I know her personally. She had started her 150 mg cc for 5 days and called her back for scan on 7th day. And because she was not doing her own scans, the scans were outsourced and the radiologist had reported there is no response. So the doctor, with a good intention that the follicle should emerge, She had added HMG 150 IU for 3 days. All the scans were not done by the doctor. It was reported as 3 follicles of 18 after 3 days of HMG. Then she asked the fertility doctor what trigger to be given, and the doctor advised her HCG 10,000 IU, seeing that there were only 3 follicles of 18 So the doctor went on to give HCG 10,000 IU, followed by IUI. So what was the outcome? It was disastrous, drastic. Patient landed up in severe OHSS, ovarian hyperstimulation syndrome. It was a severe form. She was hospitalized, ICU for months. Very, very unfortunately, her pregnancy got confirmed, multiple pregnancies, which really adds fuel to the fire. So much of physical trauma, multiple pleural tapping, ascitic tapping, so much of mental agony, emotional upheavals, too much of financial burden on the family. And also because the couple went on to sue the doctor, went to the consumer court. There were many, many medical legal implications for the consultant too. So I just want you to go through this and just check what could have been a different approach to this lady if we had a sound knowledge of infertility, how all this could have been prevented if we were more careful and if we had evaluated her better. That's the purpose of this case history, what I'm telling. So going back retrospectively, what are the factors that were totally ignored for her to land in ICU? She is aged less than 25 years, very young lady, lean PCOS, weight less than 45. We should have never added 150 mg CC and 150 mg HMG. Complete scans should have been done by the fertility doctor who was treating the patient, because the secondary follicles were never reported, and that's why that wrong trigger of HCG 10,000. Otherwise, we could have completely prevented this cascade by giving a luprite trigger, avoiding the HCG trigger. All this happened because we did not have sufficient knowledge about how to go about with this lady, giving her a healthy pregnancy. Instead, we made her land in a ICU. Luckily, she came out of the ICU, but with lot of morbidity, with lot of emotional scarring. Just ask yourself, everybody should ask ourselves, how could this scenario be completely prevented if we had sound knowledge of how to treat an infertile lady? Mehbooba Kadir have changed the names. This also, it's a sad tale. She came with history of married life 10 years. She was already 35 years, had undergone multiple cycles of OITI, ovulation induction and timed intercourse, many cycles of IUI, over 3.5 years. Lot of time, energy, money was wasted. No doctor had advised her. Ovarian reserve tests, FSH, LH and AMH was not at all done. So she did not know what is the impact of age on ovarian reserves. So much of time, effort and money of the couple had gone. Her ovarian reserves were completely depleted. She happened to land in GarbhaGudi, and when we analyzed her AFC was only, antral follicular count was 2 on the right side and 1 on the left side. Her AMH had drastically dropped to 0.4. Her day to FSH had raised to 12. So all these are indicating she's going towards premature ovarian insufficiency and failure later. So we had to tell her about the option of donor oocytes, but the lady never agreed because they wanted their own gametes. So we wanted to do a trial stimulation for her, gave her a lot of injections, hormones, but the response was very deficient. But the couple were very adamant that they want their own oocytes. So we had to counsel her repeatedly for multiple cycle of stimulation, embryo pooling, and probably a day 3 and day 5 transfer. So what was the outcome? She had to be given high dosage of HMG, HCG, FSH, very few oocytes retrieved, multiple cycles of IVF and embryo pooling was done. We have to just ask this question, could have been, the whole thing could have been avoided if we had done a proper evaluation of this couple with proper ovarian reserve testing in the initial stages tell her that reserves are dwindling, it's coming down, AMH and AFC. So better she go for a better center, higher center with better protocols than wasting her so much of time in OITI and IUI cycles. This lady, Rudali Sharma, she came with a history of married life of 5 years. She was 29 years. Husband was diagnosed to be azoospermic. Her family gynecologist had advised her donor insemination. They had done 6 AIDs, but they had got no results at all. The couple were totally shattered, disappointed. They had completely stopped all treatment for 4 years. Somehow, one of her neighbors got them to a free fertility screening camp at Kanakpura. We did their andrologist workup of the husband. Luckily for him, all hormones were normal. FSH was normal, testosterone was normal, and he was diagnosed to be as obstructive azoospermia. So as you all know, there are 2 types of azoospermia, NOA, non-obstructive, and obstructive azoospermia. As obstructive azoospermia has a very good output in form of good sperm retrievals, and we can have a successful pregnancy with their own gametes through TISA and PISA. So we went ahead, stimulated the lady for IVF, did a good TISA. We had good retrieval of sperms, went on to do a ICSI. Then she conceived in the first frozen embryo transfer with twin gestation and delivered to 1 boy and a girl. So all couple will not end up with a happy ending of this lady like Rudali, because all doctors should have sufficient knowledge how to go about in a case of infertile couple, what is the best evaluation to be done, and what is the best protocol to be put for this patient so that she can conceive. This is the main aim of this CMV, which we are starting today all over the India and all over the globe. I always feel there is a severe lack of exposure to infertility treatment protocols, though we have done our undergraduation, post-graduation from the prestigious organization, prestigious medical colleges. We don't have much exposure to the complete infertility treatment protocols for that extent that we can become a good fertility experts. This sort of infertility treatment protocols, which GGIRHR intends to create a very good learning platform. It should be easy to learn, which should be very effective and efficient, and it should give results to the practicing doctors. And it should be very affordable to and practical to use it in their daily practice. And of course, doctors can experience the amazing success rates of GarbhaGudi, which is consistently beyond 60 month on month, year on year. This is because of our adoption of latest technologies and very good treatment protocols. And we always keep abreast about the advanced treatment methodologies. And we have a very good infrastructure, very good doctors and embryologist team, which teaches the students with lot of rigor and lot of energy. We also want to inculcate the essence of right treatment of infertility, because as soon as I tell IVF center, there are so many negativities coming in our mind, but this is not so. We can have the best practices, best clinical guidelines, best ethicality, morality, and sincerity in your fertility practice. This is the main aim of the CME, to inculcate the right essence of right treatment. So we should always have good ethicality, perfect morality, and ultimate sincerity in whatever we do, be it whatever type of practice we do. So as you all know, you know the definition of infertility. It's an inability for the couple to conceive after 12 years of unprotected intercourse, 12 months of unprotected intercourse, 1 year. But if you see this graph, most of the couple, 57% of the couple will conceive within 3 months of their married life with unprotected intercourse. Almost 72% will conceive within 6 months of their marriage with proper sexual intercourse, 85% within 1 year, and 93% within 2 years. If you see a couple when they are coming and approaching you within 3 to 6 months, they are young age, they don't have any other morbidity, you can just show them this graph and tell them there is nothing to be worried of, no anxiety. It is just that most of them conceive within 1 year and you can give them sufficient time. But there are few set of couples whom should be treated and whom should be evaluated early. We have to look into those set of couples. They are where initial evaluation is warranted after 6 months of unsuccessful efforts. These are the people who are lady more than 35, men more than 40, lady with oligosamenorrhea and amenorrheic cycles, or she's already having some suspected uterine and tubal diseases like fibroids, endometriosis or something. She's already been diagnosed with stage 3 or 4 endometriosis. She might have undergone multiple surgeries for endometriotic cyst or any other cyst rupture or ovarian torsion, or it could be a reason for male subfertility. Then we have to start our evaluation earlier, not wait for 1 year of unsuccessful efforts. We have to start everything early for them. So wherever applicable, you better evaluate both partners in one go. Don't focus on just one male subfertility and totally ignore the lady. I saw one person who has been taking andrology consultation for more than 1 year now, and he brought his wife after 1 year of his normalization of the semen parameters. We found in the lady that she has multiple fibroids now. So we have to tackle the fibroids now. Again, it takes time for the uterus to heal, and then we have to start the treatment again. By the time his parameters also might come down. So it is always better that you evaluate both partners in one go. I know one lady who had undergone multiple times of OITI, and finally when the sperm analysis was done after 1 year, he was found to be severe oligoasthenoteratome. So the entire 1 year is gone. So much of money, energy, efforts, ovarian reserves, everything has gone for a shot, isn't it? So it's better we evaluate both partners in same time. So we all should be very, very wary of this age. We tend to take it very lightly. We should never do that. You should always see what is the age of the couple when they come inside. Fertility starts to decline in women from about the age of 30. It becomes very steep after 35. So we have to counsel them if they're undergoing multiple cycle of IUIs even after 35 years. We have to better caution them, counsel them, tell them that the fertility drops down, ovarian reserves drops down very steeply after 35. Most of the men remain fertile even into their 50s, but after 40s, the sperm issues increases, DFI increases, morphology, everything gets affected as the age of the man also increases. So you can see in this graph, the likelihood of getting pregnant, how it is increasing from 2034, and then it is coming to a very low, up to the baseline at 40 and 45. And how likelihood of infertility is increasing from 3% to 100% as the age advances. So you should be always aware of this fact, and you should counsel your couple showing this graph, how it becomes a steep decline in their fertility potential. So as the body ages, so also the organs also age. So also the ovarian reserves. So we have to keep a note of this and explain to the couple who have crossed their 35s and 40s. So you all know what are the causes of infertility, which falls into main headings: ovulatory dysfunctions, male factors, tubal, endometriosis. Many a times it remains unexplained, and it could be a combination of many of this, which comes under others. So while taking history, you should be very cautious to take all the perfect points about their past history, past surgical, medical. It should never be ignored. You have to spend a lot of time in taking history because you'll get a lot of good information for treating this couple. Example, duration of their married life, duration of their sexual life, what is the menstrual history, how is the menstruation going on, previous obstetric details like previous abortions, previous ectopic pregnancies, whether salpingectomy was done, or whether any surgeries were done during an unmarried period, or has she undergone any tubercular infection previously, any hormonal disorders which have been treated, any sexual history, what is the contraception they have been using, what is the frequency of coitus, any sexual dysfunction they have been observing so far. What are the medical issues like diabetes, thyroid, prolactinomas being treated? Any surgical things like laparotomies? Psychological issues, psychiatric illness for which they are taking drugs, which will have a huge impact on the fertility also. What is the family history like repeated premature menopause, any birth defects, repeated abortions? All this should be taken care in the family history. What are the current medications they have been using? Are they diabetic? Are they on any anti-diabetics? Are they on insulin? What are the thyroid drugs they are taking? What is the recent thyroid values? Everything should be made a note. Take a history of occupation, because many people who work in heated environment like chefs or any foundries or paint industries, pesticides, fertilizers, they'll have a lot of implications on their semen analysis, and also about detailed history about their addictions like tobacco usages, alcohol, smoking, etc., which has a huge impact on the fertility potential of both men and women. Do a proper physical examination, check their BMI, because obesity has a huge role on infertility. Check for the thyroid status, thyroid swellings, nodular swellings. TSH and prolactin should be noted. Check for the breast examination, any masses, any expressible galactorias. Check for any signs of hirsutism, androgen excess, acne, lateral balding. Abdominal examination for any scars, previous surgeries, or any laparoscopic marks. You have to do a thorough pelvic examination. See for the vaginal nodularity, cervical abnormalities, secretions, discharges, infections. Make a note of everything. See whether the uterine size is normal, completely retroverted or antiverted, or is it completely gone and stuck in the POD, whether it is very nodular and tender. Check for adnexal masses, cul-de-sac masses. Make a note of it in your case notes. We have to do a thorough evaluation of diagnostic evaluation of the ovary, uterus, cervix, tubes, and peritoneum. You know, as the ovary has three main types of dysfunction. First is the central origin, hypogonadotropic hypogonadism. Second is the peripheral polycystic ovarian syndrome, that is normogonadotropic normoestrogenic. And the third will be premature ovarian failure, that is hypergonadotropic hypoestrogenic. So each of this will have a different hormonal profiles. For example, in the first one, the FSH and LS will be very low. In the normogonadotropic type, usually the LH will be high, FSH-LH ratio will be reversed. In premature ovarian failure, the FSH-LH will be very raised because of the ovarian failure. So you should know which category of the dysfunction your patient will fall into. So you have to evaluate your ovulatory function by taking a proper menstrual history. Basal body temperature is not used, not sensitive, not specific. You can go for serum progesterone or monitor your urinary LH. Endometrial biopsy is sometimes advised, but it is invasive. It's better avoided. Serial transvaginal scan gives us all information, whatever we need about the ovulatory function, how it is a follicle developing, when is the follicle rupturing, how is it converting into a corpus luteum. All information can be got if you are a good sonologist. Serum progesterone usually, when it is more than 3, it gives you a presumptive evidence of ovulation. If it's more than 10, it correlates very well with in-phase endometrial histology and also tells us that this lady has a very good luteal support. Urinary LH, we were using a lot previously, but it is not very sensitive and accurate. Usually when you want to time the ovulation induction and timed intercourse, you can do a urinary LH test. And after 24 hours, you can tell that the lady is about to ovulate and you can time the intercourse. Transvaginal ultrasound, very good investigation for baseline evaluation, how the uterus is functioning, how the ovaries is functioning, for check the antral follicular count, check for any fibroids or any polyps or endometriotic cysts, check all the pathologies, start your ovulation induction, keep tracking the follicle, check till follicular growth till 18 to 20 mm and check how it ruptures and converts to a CL cyst. Also, you can have lot of evidence of ovulation. Transvaginal ultrasound is a boon for ART procedures like IUI under ultrasound guidance, OM pickups, ETs, everything is done under ultrasound guidance. Even after conception, if you want to rule out any abnormal pregnancies like ectopics, you need a thorough scan knowledge. There are many ovarian reserve tests. So you know here, AMH, as the age advances, how from 35 to 41, AMH is dropping down drastically. FSH is increasing from 6 to 20, and AFC is falling down from 13, 18 to 4 and 5. So you should be very cautious. As the age advances, your ovarian reserve test should be done, and you should correlate that with the age. So this chart tells you ovarian reserve tests. There are 4 types: biological, biochemical, biophysical, and histological. Biological is the most important, that is chronological age. Biochemical means static and dynamic. Static is FSH estimation, inhibin B, E2, and AMH, whereas dynamic is clomiphene challenge test, gonadotropin stimulation test, and exogenous follicular stimulation test. Biophysical is ultrasound, where we do a AFC, antral follicular count, ovarian volumes, and also check the ovarian blood flows. Histological is invasive ovarian biopsy. Usually it is not done. These are the different types of ovarian reserve tests which we can do for a lady to know where she fits in. So next come the uterus evaluation, which is very important. You should know whether the uterus is normal or abnormal with any anomalies like unicornuate uterus, bicornuate uterus, or is it a septate uterus, whether there is intrauterine adhesions, or is it studded with many fibroids, or do you have many endometrial polyps, which is interfering with the implantation procedure. So you have to evaluate the uterine anomalies either by a HSG or a combination of 2D and 3D ultrasound and transvaginal ultrasound, or histoscopy and a laparoscopy, which gives us a fair idea what's the issues with the uterus. So in HSG, you can have a very good idea about size and shape of uterine cavity, any developmental or acquired abnormalities, and also the potential reproductive consequence. This is a very good HSG film. See how the dye has gone into the uterus, delineating the entire cavity. Beautifully, the tubes are very supple, floating, and how the dyes have been coming out from the fimbrial end, showing the patency. So such good as HSG films can give you a lot of ideas about what is happening in the pelvic cavity. Here in this HSG film, you can see the logging of the dye on both the tubes. So it is telling us that it is a fimbrial phimosis with logging of the dye on both ends. So this is blocked distal ends of the tubes. Ultrasound is used to diagnose uterine pathologies like myomas, adenomyosis. If you combine it with sonohysterography, when you are instilling saline into the uterus, you will see polyps, submucous myomas, synechiae. It gets very well delineated on sonohysterographies. So this picture shows that myometrial hyperplasia is there, and the anterior wall is 3.13 centimeter, posterior wall is 1.7. There is total hyperplasia, heterogeneity of the entire myometrial walls, showing that it is a adenomyotic uterus. Histoscopic abnormalities, you can see here as you put the scope, there is a complete septum dividing the cavity. So this could be the reason for her repeated abortions or not conceiving. Here the entire cavity is filled with intrauterine adhesions as well as septum. Probably previous failed attempts to resect the septum has resulted in such bad adhesions. There is an endometrial polyp here near the fundal cavity. So this could be preventing her implantation process. This is a submucous fibroid entirely occupying the cavity, which is resulting in infertility in this lady. This has to be resected. After that, HRT given and she'll conceive after that. Evaluation of the tubes, you all know it is done by HSG, laparoscopy, fluoroscopic and histoscopic tubal cannulations also. All methods are complementary and they're not mutually exclusive. You can diagnose tubal occlusions, whether it is proximal distal or a hydrosalpinges. It could be a salpingitis systemic nodosa due to tubercular infection. Fibroid phimosis could be there. Peritubal adhesions could be there. All this can be evaluated by HSG investigation to know the clarity on the tubal patency. So in this, you are seeing the entire cavity first film is completely obliterated with multiple fluid levels, multiple intrauterine adhesions. In the second film, you can see the dye is completely stopping at the proximal ends of the tubes. So it's proximal tubal occlusion. The third is showing us complete hydrosalpinges on both sides, completely blocked tubes. So the female genital tuberculosis has resulted in such scarring of the cavity and such bad proximal tubal blocks and hydrosalpinges. Laparoscopy, definitely it's an invasive procedure, requires admission, and it has to be done by a well-equipped surgeon, well-equipped OT and a skilled surgeon. It can give us so many things about like diagnosis and treatment in one sitting. It cannot be done for everybody. It is not a blanket treatment. It evaluates our fallopian tubes, ovaries, tube-ovarian relationships. You can see the pelvic peritoneum, check for the endometriotic nodules, see for the ovarian positioning. You can do a lot of therapeutic uses also like lysis of adhesion, excision and treatment of endometriotic cysts, fulguration. You can go ahead with planned myomectomies and tubal reconstructive surgeries also. If it is a PCOS lady who is not at all responding to your treatment, ovulation induction, and her FSH-LH ratio is completely altered, you can properly plan a good drilling. If they have large cyst, you can plan a cystectomy too in the same sitting of laparoscopy. It can evaluate the complete pelvis, give you a lot of details in modifying and having a good follow-up plan for this couple. You have to consider laparoscopy early. When the age is 35, she's completely completing 3 years of married life. You're already seeing an abnormal HSG. You have history or symptoms suggestive of pelvic disease like dyspareunia, dysmenorrhea, or she has history of previous pelvic surgeries done, then you have to consider laparoscopy early. So what are the take-home messages? Very, very important. Check the history of an infertile couple thoroughly, efficiently, effectively. Age of the couple is very, very precious. Be cautious when they are crossing 35. Evaluate the couple, and it is very essential to plan the next step. Do a proper, thorough male workup too, because it is most often missed and it's completely ignored. Don't go for very, very fancy procedures like ICSI, IMSI, PICSI in the first setting itself. Do a proper right evaluation, give a very good evaluation for that couple and do a good treatment protocols for them. Evaluate the ovarian reserves early so that you will have a fair idea how the lady is responding to your treatment protocols. Tubal evaluation by laparoscopy is the gold standard, especially when the lady is failing with multiple IUIs. Then have a good tubal evaluation done. AMH less than 1, AFC less than 4 to 6, age more than 45. Kindly refer them to a good higher center for proper evaluation and treatment and for more of IVF cycles. If they're already having IUI failures more than 4, husband is having DFI more than 25, their married life of more than 5 years, kindly refer them to a good fertility specialist and good fertility center. This lady by name Sindhu Pandian, she was only 26 when she came. He was 30. Primary infertility of 3 years. Her menstrual cycle was very irregular, once in 2 to 3 months. Most of the cycle were only with progesterone withdrawal. Husband was working in a very heated environment, glass article manufacturing factory. He was always exposed to heat. Past medical history, she was on Thyronorm 100, but it was not controlled. Family history, nothing significant. So there was history of smoking occasionally and drinking also in the husband. Mother had diabetes and hypertension. Investigations were done at GarbhaGudi. The husband had an abnormal oral glucose challenge test, which was treated with lifestyle and anti-diabetic drugs. He was hypertensive. He was started on antihypertensive medications too. Wife was examined. Her BMI was 28. Features of hirsutism were not there, but she had severe acne. Blood workup was done. Note here, she's taking 100 microgram of thyronorm, but her TSH is 6.63. For any good fertility, the TSH values should be less than 3, ideally 2.5. Her prolactin is very low, though she was not treated for that. AMH is high. Baseline day 2, day 3 FSH when is done, FSH was less than 0.1, which is usually between 4 to 7. LH is also less than 0.1. Normally it is less than 5. And E2 is also low. So if we had not done these investigations, we wouldn't have known that such low hormonal profiles are existing in this lady, isn't it? So did an ultrasound, both ovaries showed a polycystic ovarian morphology, 16 to 20 AFCs on both sides. Ovarian volume was high on both sides. So because her hormonal profiles were also abnormal, we did a MRI and it came to be partial empty sella syndrome. So this diagnosis could have been completely missed if you had not done a proper hormonal analysis and if you had not done a MRI. So we would have been treating her with ovulation induction drugs, telling that she's not responding to any of our medications. So thorough evaluation is very, very important. Just because now we know she's empty sella syndrome, so she has to go with only injectable drugs for her stimulation. So what we did was called her on day 2, started with HMG 75 international units for 7 days. We cannot change frequently the dosages of HMG because she has 16 to 18 follicles on both ovaries. So if you frequently change the dose, you will land up in the first case history, which I told you, severe OHSS. Called her after 9 days, there was no dominant follicle. So we slowly converted into HMG 150 IU for 5 days. Then the ovaries started responding on day 13 and day 14. It started developing 11, 10.5. Day 15, it became 14.5. And day 18, follicles were ready for the trigger. So this is only HMG induced induction for her. The trigger option is only recombinant HCG because she's a hypo because of the empty sella syndrome, and no other leupride trigger will work on her because there is no FSH and LH production in her pituitaries. So only injection which we can give here as a trigger is her recombinant HCG, that too 250 micrograms. Her peak E2 on the day of trigger was 1497 and LH was 0.88. So trigger was given and IUI was planned. We did a IUI, one after 14 hours of the trigger and one after 36 hours of the trigger. Then gave her a good luteal phase support. We started on the second IUI day. Dihydrogesterone 10 mg TID and micronized progesterone 400 mg PV per vaginal BD for 15 days. She came for UPT positive on 15 days after IUI, and it was a singleton pregnancy. Cardiac activity appeared at 6 weeks. She continued 9 months and she delivered a baby boy. So if the evaluation has not happened properly, she would have gone from doctor to doctor without any success, and she would have been frustrated and given up all treatment cycles, isn't it? So we should have a sound knowledge of infertility to know when to start, how to start, and when to end. So case highlights. Its evaluation is very, very critical, crucial. She's a case of empty sella syndrome. Clomiphene citrate, letrozole, and tamoxifen are all ineffective. Only thing which can act in this lady is HMG, and only trigger we can give is HCG. So as you all know, empty sella syndrome has 8 to 12% incidence. It's a defect in diaphragmatic sella covering the pituitary, which allows the CSF fluid to leak, which presses the pituitary and harms the pituitary. So pituitary gland can also be damaged by tumor, surgery, infections, and radiation therapy. So we should be aware of this syndrome. This was a case of partial empty sella. It could be a complete also. So I just want to emphasize this take-home messages once again, because it's very, very critical. What we learn from this case. So history of an infertile couple is very, very important, both female and male. So we have to spend our time in that. Age of the couple is very, very precious. Doctors should be very, very aware of that. Evaluation should be done very, very methodically to plan the next steps. You have to do a proper male workup, which is most often missed in many of the clinical setup. Don't go for any fancy procedures, right? Go. You have to do a right evaluation to give the best outcomes to the lady. Do a proper thorough evaluation of the ovarian reserve testing, at least in form of a proper transvaginal scan, a proper anti-follicular count if they are not willing for any blood tests. Do a thorough evaluation of tubes, because many of the HSGs we see, both tubes are blocked, but it is reported as patent, and the doctors keep on doing IUIs without even checking the HSG film once. When the AMH of the lady is coming less than 1, the alarm bell should start ringing in the heads of the doctor as well as patients. AFC less than 4 and 6, age more than 35. Please don't try with one more induction of clomiphene citrate cycle, one more IUI, one more OITI. They have to be referred to a good fertility center. When there are IUI failures happening more than 4, when the husband semen parameters are dwindling, DFI is becoming high more than 25, married life is crossing 4 to 5 years, you have to be very, very cautious in referring the couple to the good IVF center, because when they come in the late stages, when there is no ovarian follicles at all in the lady, AMH is very low, even IVF cannot be offered to them. They'll be in a state of shock. So these are the take-home messages which you have to be very, very cautious. Thank you so much for that patient listening.
Thank you, Dr. Asha S. Vijay, for your wonderful and informative session and on how to thoroughly evaluate the couples for successful outcomes. Thank you, ma'am. I now take the honor of welcoming Dr. Maheshwari, ma'am. Dr. Maheshwari Mohan Kumar is the Assistant Medical Director in GarbhaGudi. She has done her MS Obstetric and Gynecology and Fellowship in Reproductive Medicine. She has more than 11 years of overall experience and 6 years as a specialist. She has gained good experience in managing infertile couples with various infertility problems. She is well versed with counseling, procedures of third-party reproduction and diagnostic hysterolaparoscopy. Dear participants, please post your questions in the chat box and we should take up the questions at the end of the session. Welcoming Dr. Maheshwari, ma'am. Over to you.
Thank you, Ulfat. Happy afternoon, dear doctors. So today I'll be discussing about evaluation of infertile male. So as Dr. Asha ma'am has discussed in detail, about the evaluation of female, so many points we miss out, so many important things. Time is an important factor when we are treating an infertile couple. So what nowadays, what is earlier, what the awareness was very less, especially if you see during your PG teaching also, there is not much about infertility treatment, like how to evaluate, nothing much is discussed. Even how to do an IUI, even the setup is not there in many of the medical colleges, even to do a transvaginal scan as well as the IUI. So that's why we have lot of we don't have lot of exposures to the infertility, especially when it comes to infertile male. So whenever when we are evaluating in the peripheries, in a government setup or even in a medical college OPDs, what we do is we try to evaluate only female partners and we just do one semen analysis, that too very rarely in few centers they will do. So now in this class, what I want to highlight is what are the important things we are missing out when we are evaluating the infertile male, what is important in the history, what are the things we have to ask, and how we have to evaluate, how to interpret the results, and how to give the proper treatment so that couple can have a healthy baby as early as possible. So I'll be discussing mainly about evaluation of the male factor here. So male factor evaluation should be synchronized with the evaluation of female partner always. It is not like we will evaluate the female partner, we will give 2 or 3 cycles of ovulation induction and then we will evaluate the male factor. Nothing like that. Both male as well as female partners should be evaluated at the same time. So this is the normal anatomy of the male reproductive system. I think all of you are aware of it. So important structures are seminal vesicle, prostate gland, and also bulbourethral gland. And here, if you see, there is a testis, epididymis, the scrotal sac, as well as the all these the male genitourinary tract. I'm not discussing this in detail. Just few important organs which produces certain things. So when we come to the testis, main part is what we have to do is when we see in the microscopic view. So these are the seminiferous tubules. So why I'm explaining this is like when I start about semen analysis, semen production, this is very much important. That's why I'm just briefing the structures. So these are seminiferous tubule. So, and also seminiferous tubules are coiled and they are connected to a straight tubules and then they form a plexus and then they go into the epididymis. So they form a plexus. This plexus is called as rete testis. From the rete testis, the efferent ductules forms. From there, the sperms goes and gets collected into the head of the epididymis. So this whole structure, the arrow point, if you can see, this is the head of the epididymis. These are the body of the epididymis and this is the tail of the epididymis. And from there, you can see here, the vast difference comes. So this is a normal structure. And if you see the layer, so this is a tunica vaginalis. This is the parietal layer. This is the cavity and this is the visceral layer. And this blue, light bluish color is called as tunica albuginea. It is a capsule of the testis. So this is the microscopic view of the testis. So and its structure. So microscopically, if you see, so when you see the seminiferous tubules, this round ones are seminiferous tubule. Inside the seminiferous tubule, see the sperms. So in the center, these are the sperm. And see the secondary spermatocytes. These structures are secondary spermatocytes. This in the center is spermatid. These are secondary spermatocytes and these are Sertoli cells. Sertoli cells are supporting cells. And there are other primary spermatocytes also. So if you can see, this is primary spermatocytes, secondary spermatocytes, the spermatids, the Sertoli cell, and also the other cells, these light pinkish cells which are outside, they are the Leydig cells. And also in the basal layer, we have the germ cells. These are called as spermatogonium. So this is how the spermatogenesis happens. I'm not going in detail about that because all of you are aware of it. I'm just explaining this so that, so what structure and what is the function of it, I just wanted to explain. So if you see the seminiferous tubule, the main function is spermatogenesis. When it comes to the epididymis, here the sperms are collected and sperm maturation happens in the epididymis. And if you see the ductus deferens, it propels the sperms to the ejaculatory duct. And seminal vesicles, they provide the nutrients for the sperms and they help in coagulation of the semen. And also prostate gland also produces certain enzymes, proteins, which helps in liquefaction of the semen. So if the prostate secretions are not there, what happens? There is no enzymes or the protein to break the seminal fluid. So it will be very thick. So for the liquefaction to happen, prostate gland secretions are very much important. And then bulbourethral glands also contributes. They add alkaline mucus to neutralize the prostatic acid and vaginal acidity. So whatever the secretions which comes from the prostate gland is acidic, as well as in the vagina, the pH is slightly acidic. So the sperm cannot sustain that acidity, So that's why bulbourethral gland, they produce certain alkaline secretions, alkaline mucus mainly. So that's why these are the few important structures which are involved in the spermatogenesis and their normal structure. So in general, if we see the causes for male infertility, so we can divide it into pre-testicular, testicular, and post-testicular causes. In the pre-testicular causes, the main problem is in the hypothalamus and pituitary. So hypothalamo and pituitary diseases, it causes 1 to 2% of the overall cases. So in that, most common thing is genetic disorder. In the genetic disorder, main thing is anosmic GNRH deficiency, that is Kallman syndrome. The other acquired conditions are pituitary and hypothalamic cyst or tumors, the head trauma, radiation, if there is any radiation to the base of the skull is given, if hyperprolactinemia is there, and also certain drugs like corticosteroids, opioids, androgenic and anabolic steroids. These are all the causes for pretesticular male factor infertility. So, and also the treatment for this is mainly the hormonal supplement. This I will discuss in detail. The other things are testicular. Next main comes is the testicular cause. It is mainly the gonadal failure. Here the synthesis of the sperms is not happening properly. This constitutes to 30 to 40% of the cases. The causes for this gonadal failures are mainly, one is congenital genetic or chromosomal problems like Klinefelter syndrome, Y chromosome microdeletions, and also the acquired causes like cryptorchidism. If the testis is not descended properly, if there is a viral orchitis, if there is a varicocele, or irradiations to the gonads or the structure close to it, trauma to the testis, and also chemotherapy. So this testicular damages, if it is very severe, most of the causes are non-reversible causes. Coming to post-testicular causes. The post-testicular causes are mainly because of disorders in the sperm transport. Here the sperm is synthesized properly, but the transport is not happening. That's why the sperm count is less, or the sperm is not seen in the semen. So this constitutes to 10 to 20% of the cases. The main causes for the sperm transport problems are mainly because of congenital bilateral absence of vas difference. If the vas difference is absent, then it causes post-testicular causes of male infertility. The other things are cartilaginous syndrome. It is mainly because of primary ciliary dyskinesias, and also the acquired infections like tuberculosis, gonorrhea, chlamydia, and cystic fibrosis. And the surgical causes like if the vas difference is removed, or if there is any retrograde ejaculations. So these contributes mainly the post-testicular causes. There are many other causes. I've highlighted here main important causes. So the other causes involves infrequent vaginal intercourse, mainly because there may be like a problem with the male because of erectile dysfunction or premature ejaculation, something, or the female may be having severe dyspareunia. It may be psychological, or it may be like because of they are working in different conditions. So those are the causes. So, and also the other things are drug induced causes because of all these things. So, and also the psychological causes are there. So these are like if there is any majority of the, mainly this post-testicular causes, if it is a drug-induced or psychological causes can be treated with medications, and drug-induced we can see and we can taper it. And if it is an obstructive cause, we can do a microsurgery and we can do the IVF and treat it. So treatment part I'll discuss in detail later. So the other one of the causes, few causes for male factor infertility as well as female factor infertility. Few cases are there, those are called as idiopathic. Sometimes everything comes normal, still they are not able to conceive. They come under the category of unexplained infertility. And the risk factors for this kind of male infertility, main risk factors are, one is any form of severe disease, systemic diseases like cirrhosis, chronic kidney disease, smoking, heavy alcohol, like if they're taking too much of alcohol, obesity, malnutrition, drug addictions, so anabolic steroids, if they are taking, all these are risk factors for male factor infertility. So in general, causes for the male factor infertility, the main thing is nowadays what we are seeing is increased paternal age. So all of you, like in the previous session, you have like Asha ma'am has explained you in detail about like how age plays an important role in female fertility. Similarly, even in the male infertility, age plays an important role. So if the paternal age is increased, what can happen? One is sperm chromosomal abnormalities can happen. The other are adverse fetal outcomes like increased autosomal dominant diseases like achondroplasia, craniostenosis, and also Down syndrome risk is high. Few studies have noted. So, and also like even though if we are using a donor sperms, we usually take less than 35 years, and in some countries they prescribe less than 40 years age person's sperm should be used if they are using for sperm donation. So why we have to evaluate, why we have to know all these things? One is to identify the potentially correctable causes. Few causes are definitely correctable in 1 or 2 months. If you control it, definitely the fertility will come back. To identify those correctable conditions. The others are irreversible conditions that are amenable to assisted reproductive techniques using the sperm of the male partner. Suppose if it is very severe HOTS or azoospermia obstructive, there we can do a microsurgery and take out their sperms and do the IVF and they can conceive. We can use their own sperms. So those conditions we have to check. And also we have to identify the irreversible conditions that are not amenable to ART treatments, but for which donor insemination or adoptions are possible options. So evaluation is mainly to identify the correctable cause and also irreversible cause where we can use the male partner sperms only, and also to identify the irreversible cause where we cannot obtain the male partner's sperms, we have to use the donor sperms only, or we have to advise the couple for adoption. So these things are there. So now coming to cornerstones of evaluation. One is initial screening. Here we have to take a thorough history and physical examination. We have to do a semen testing on 2 different occasions, 2 to 4 weeks apart. And other ancillary tests like hormonal evaluation, imaging, and genetic testing is required. So coming to history taking, we have to ask in detail what is the duration of infertility, whether and also whether any previous issues. Issues means previous pregnancies. So whether it is primary or secondary infertility, we have to ask. And also we have to ask in detail about the sexual history. Is there any difficulty during sexual intercourse? And in the medical history, what all the things we have to keep in mind. So always when we take male partner history, it will be short, like even 3 or 4 sentences in that will finish off the male history. But we have to take everything in detail. That's why I put a tableau chart so that you can understand better with this. So we have to ask in detail about recent febrile illness because they cause depression of spermatogenesis for approximately 6 months. So any infections, they can affect the spermatogenesis for approximately 6 months. And also history of mumps, TB, orchitis is very much important because they cause testicular damage. And also history of sexually transmitted diseases we have to ask because they cause obstruction. History of renal failure because they cause testicular failure. And also if the patient has any liver disorders, chronic liver disease, and also cirrhosis, all those liver failure, acute any hepatitis or anything. So because it causes hormonal synthesis and hormonal abnormalities, thereby it can cause infertility. And also radio and chemotherapy, they cause testicular damage. And multiple sclerosis causes ejaculatory dysfunction. Diabetes mellitus causes ejaculatory dysfunction, and spinal cord injuries also cause ejaculatory dysfunctions. So coming to past medical history is very much important because if the patient has undergone any orchidopexy, mainly because of maldescent, like so non-descended, undescended testes, or if there is any torsion, surgery would have been done. Or if vasectomy was done, it causes obstruction. If inguinal hernia repair was done, it causes obstruction. And if there is any pelvic scrotal urethral surgeries, they cause ejaculatory dysfunction or obstructions. So prostatectomy causes ejaculatory dysfunction, and so any retroperitoneal surgeries or sympathectomy, they cause ejaculatory dysfunctions. Coming to drug history. So if they are taking any drugs for the any medical disorders, few drugs, they are known to affect the sperm synthesis as well as they cause male infertility. We should be aware of those drugs. One is cimetidine because it is anti-androgen, and spironolactone is anti-androgen. Anabolic steroids, they affect the gonadotrophin secretions. So GnRH agonists, they affect the gonadotrophin secretions, and chemotherapy, because it causes testicular damage. Coming to occupational exposure, because excess heat causes testicular damage. So this occupational history is very much important when we are taking in detail the history. So initially you have to ask what occupation. So that is very much important. If they are exposed to excess heat, especially if they are working in a factory, or if they are working in a cooking like hotel business, or they're cooking for a long time with increased heat exposures, or long duration of traveling, long duration of standing. So all those things are very much important. And occupational exposure, if they are working in a radiation where the radiation exposure is more, example like a X-ray technician, or those who are working in radiotherapy unit, and also like if they are exposed to certain chemicals which are very dangerous, which are gonadotoxic in chemical factories, or if they are using certain fertilizer which are very harmful, all those things we have to ask in details. Each and every point in the history, it gives a clue to the diagnosis of the disease and also helps in the management of the things better. Few small things, few small modification definitely can give a good results. And radiation exposure causes testicular damage. Alcohol or drug, if they are taking too much of alcohol, or if there is any addiction to like drugs, cocaine and all, so that causes testicular damage. And also even the environmental pollutants can cause testicular damage. Coming to systemic review, like we have to ask if there is any history of headache or visual disturbances, because it gives a clue on pituitary tumors. And also if there is any anosmia, it causes Kallmann syndrome. If there is any galactoria, it causes hyperprolactinemia. So recurrent respiratory tract infections are associated with Young syndrome, and gynecomastia causes hormonal imbalance. So how we have to evaluate it? Evaluate, first thing is history, as I explained. I'll just explain few important points. One is history of smoking, because it decreases the sperm motility and count. Occupational history of the male partner, whether they work in glass factory, daily long journey, tight scrotal support, anything is there. History of sexual history, frequency and timing of sexual intercourse, sexual dysfunction, history of sexually transmitted disease like gonorrhea, TB, chlamydia. History of surgeries like for cryptorchidism in childhood and varicocele repair, and drug history like beta blockers and anabolic steroids, and also history of chronic illness, which is a contributory factors, and also family history of infertility is very much important because it suggests the genetic predisposition. This is in short about the history. So, and also like nowadays we are there is lot of use of this mobiles as well as Wi-Fi radiations and all, no? So there are so many papers, research papers which are coming up, so which are telling like there may be effect of electromagnetic waves from the mobile phones on sperm synthesis, its motility, its count. Definitely it is going to affect. So more research papers has to come to give a conclusive evidence. Definitely many research papers have shown that use of mobile, too much of mobile and too much of electromagnetic radiations are going to affect the sperm parameters. So when it comes to the male fertility evaluations, so we have to check for the medical, surgical and developmental history. So we have to ask for medications and habits. So we have to do a physical examination. We have to do a standard semen analysis, hormonal evaluation. So if required, genetic counseling and evaluation and imaging studies as needed, like scrotal ultrasound and all. So coming to the physical examination, so we have to assess for the secondary sexual characters. We have to see their height, BMI, body air. Is there any gynecomastia? And also we have to examine the scrotum as well as the testicles. So examination of the testicles to see for any undescended testicles, whether it is very small in size, that is neonatal testicles, retractile testicles. Is there any abnormal testicular mass? And also scrotal skin abnormality for genital warts. So, and also we have to check for epididymis to check for any swelling or congestion. So we have to see whether there is any inflammation or infection within the epididymis, which makes it extra soft and tender. And we have to check, is there any varicocele or not? It is easily visible during physical examination. So, and also like we have to do the examination of the penis to check for the location of urinary meatus, to check for any hypospadiasis or epispadiasis, and any discharge of fluid from the opening of the penis, and also infection either in the urethra or in the genital duct system. So coming to the tests which are done for male infertility. So what we do is mainly the semen analysis. The other next step is scrotal or transrectal ultrasound, karyotyping, and Y chromosome microdeletion analysis. Coming to semen analysis. So semen test, like it is a basic test. It is a must to decide on the further treatment of the couple. So usually the semen, 60% of the seminal volume is because is secreted by the seminiferous tubules. So they have a high fructose and also it causes the coagulation. So and also 20% of the seminal volume are secreted by the other glands like prostate and bulbourethral glands. So they contribute 20% of the seminal volume. They are milky in appearance. They have a proteolytic enzymes, and also they have a spermin which helps in the sperm motility. So, and also like 5% of the, like less than 5% of seminal volume, or mainly because of the other secretions. And when it comes to the there are different editions of WHO regarding the semen analysis. So the recent one is the 6th edition. Earlier we used to refer to the 5th edition. So now from 2021 onwards, we are using the 6th edition of WHO manual. So if you see over the year from 1980 to 2021, so 6 editions have come. So earlier, last back 2 years back and all, till 2 years, like 2 years back or 1 year, 1.5 years back, we were using this WHO 2010 5th edition of as a standard count. So if you see the difference between, not much difference between the 5th and 6th edition. So I'll explain the 6th edition. So in the 6th edition, according to WHO 2021 volume, so the volume of the semen sample should be at least 1.4 ml. And the sperm count, so should be 16 million per ml. Total sperm count should be 39 million. So, and also like total motility of the sperm should be 42%. Total motility should be 42%. Progressive motility should be 30%. And vitality should be 54%. And morphology should be 4%. And leukocyte count should be less than 1%. So I'll just give 10-20 seconds for you people to take the photo of this. So because in majority of your textbook, it is what the 5th edition is given. So this is the latest 6th edition modifications. You can take a screenshot. You can take a photo of this slide. And if you see the changes between the 5th and 6th edition, in the 5th edition, the volume is 1.5, whereas in 6th, it is 1.4 normal. And in the 5th, the total, the sperm count per ml is 15 million. Here it is 16 million. So, and also if you see the total sperm count, it is 39 million. It is 39 million same in 6th edition also. So progressive total motility was 40% normal in 5th. Now it is increased to 42%. So, and also progressive motility was 32% in the 5th edition. So here it is increased up to 30%. And also sperm vitality of 58% was normal according to 5th edition. Now it is 54% and morphology is 4%. So in this slide, if you see, in 1980, 80% of the sperm morphology, if it is 80%, then it was normal, more than 80. In 87, it reduced to 50. In 92, it reduced to 30. And in 1999, it is 14%. Now it is 4%. So there is gradual tendency of, there is reduction in the sperm morphology because of various lifestyle factors and various other factors. So now at least if 4% of the sperms are normal, then we are considering it as normal. There is a lot of changes which is going on. So coming to semen analysis. So here when we are doing semen analysis, by masturbation, we will collect the sample. 2 to 7 days of abstinence, usually we will tell. So, and also if the abstinence duration is more, what happens? The sperm vitality decreases, the sperm progressive motility decreases, and also chromomycin A3 becomes positive. If the abstinence day is less than 2 days, what happens? The sperm concentration may also be less, and also it improves the percentage of sperm motility may appear little bit more, and also seminal volume will be less if the abstinence day is less than 2 days. That's why 2 to 7 days of abstinence is advised. So when we take the semen sample, we do the macroscopic examination as well as microscopic examination. In the macroscopic examination, we'll check for the volume of the semen. So here in this diagram, if you see, you will see the volume of the semen. So we see for the viscosity and we see for the pH, and also microscopically we will examine for the rest of the parameters. So in the semen parameters, as I explained, the pH should be more than 7.2, volume should be more than 1.4 ml. So sperm concentration should be more than 16 million per ml. Sperm count should be 39 million per ejaculate. Total motility should be 42%, progressive 30%, normal sperms 4%, vitality 54%, and WBC less than 1. So the most important criteria is the sperm concentration we take. Count we will not take. Sperm concentration, that is 16 million per ml, and also total motility. That is very much important. Count, motility, and normal forms. These three are very much important when we are reading the semen analysis. So, and also the normal forms of 4%, they reflect the capacity of the sperm function. They reflect the capacity of sperm to fertilize. So the criteria to assess the sperm morphology, what we use is the strict criteria or Kruger-Tyberberg criteria. So I'll just skip that part. That is about the semen analysis. The basic thing what you have to see is those three features. If you want to take a photo of this slide, please take it. So I'll just pause for 10 seconds. Okay, I'll just move on to the next slide. So the what are the abnormal semen parameters we see? One is if there is no semen, it is called as aspermia. So if there is absence of sperm in the semen, it is called as, if there is no semen at all, then it is aspermia. There is a semen, but there is no sperm, then it is called as azoospermia. And oligospermia means count is less, that is count is less than 16 million. And also like severe oligospermia is called when this count is less than 5 million. So abnormal, and also like a morphology, if the morphology is less than 4%, then we call it as teratozoospermia. And also like if the motility is less, so then the prescribed, we call it as asthenospermia. So, and also if the dead sperms are more than 54%, we call it as necrozoospermia. At least 54% sperm should be viable. If it is more than 54% are dead sperms, then it is called as necrozoospermia. If there is a loss of acrosomal cap, it is called as globozoospermia. So when we do the semen, like how we have to go about. So since I just wanted to explain you the like how we do the workup, so I've just put the slides just like how we do the workup in our fertility center, so that it will be easy for you to follow and easy for you to understand. So when we do the semen analysis, we do a workup. So if it is a normal, so we do like depending upon the indication, we check for DFI, that is DNA fragmentation index. So if that DFI is also normal, no additional workup is required, provided there is no sexual dysfunction. We'll just stop it there only. But if the decreased semen volume is there, then first thing is they may not have collected properly, or it may be a partial retrograde ejaculation. So we do a microscopic analysis of post-oxamic urine. After he gives the sample, we'll take out the urine sample. After collecting the semen sample, we'll take the urine sample and we'll check for the semen analysis. And if the sperm count is reduced, then we will evaluate, like we do a scrotal scan, transrectal scan, then we do a FSH-LH hormone analysis and testosterone hormonal analysis. And if the morphology, if there is abnormal morphology or motility, then we will check for any other rare genetic disease. So in the semen analysis, if you see, in our center, we do a CASA, that is computer assisted semen analysis. So here it is, everything will be analyzed, in each and every sperms will be analyzed, their motility will be analyzed, and their morphology will be analyzed using a software. So the main advantage of this is it is more objective and reproducible measurements are there. So it is superior documentation of the laboratory values, and it is superior in measurement of sperm motility. These are very good. So the disadvantages, it is not reliable if the sperm density is less than 2 million or more than 50 million. Lot of debris or immotile sperms, if it is there, it may not be very much reliable. So the required dilution, there is a required dilution if the sperms like viscosity is high or something, that in the lab they will analyze. So here we need to record 200 sperms for accurate distribution of velocity. At least we should have 200 sperms to do a proper CASA analysis. The parameters are not standardized between laboratories, and it is difficult to interrupt the results. So sometimes it is not like whatever the machine or CASA which is used. So it is not standardized throughout India. So it varies from manufacturer to manufacturer a little bit. So, and also there is no improvement on the manual method in distinguishing fertilizing capacity of the semen. So either if you do a manual semen analysis or if you do a CASA, computer assisted semen analysis, they cannot differentiate the fertilizing capacity of semen. They can only tell the count is this much, motility is this much, morphology is this much. They cannot tell whether this sperm is going to fertilize better or not. So coming to like the other causes. So the GnRH is secreted by hypothalamus, which acts on the pituitary, and that secretes FSH and LH. So this FSH acts on the Sertoli cell and LH acts on the Leydig cell. So FSH acts on the Sertoli cell, produces spermatogenesis, whereas LH acts on the Leydig cell and produces testosterone. So, and also Sertoli cells secretes inhibin, which in turn inhibits the pituitary gland to secrete the FSH and LH. So, and also the testosterone is converted into estrogen and prolactin. So the estrogen and the prolactin as well as testosterone, they have a negative feedback on pituitary gland. This is how a negative feedback as well as positive feedback loop works in the synthesis of semen parameters. So this slide I just explained because I'm going to explain the role of the hormones in male infertility, and it helps in the like understanding of better. So if there is any like very severe oats, like count is very less, and if there is azoospermia, then we are going to do a hormone analysis. Mainly we check for testosterone level and FSH. The other things we can check is LH and prolactin. So if the testosterone value is decreased and FSH is increased, it indicates it is a gonadal failure. So it is gonads are not functioning properly. So example, shrunken testis. So we have to do a karyotype to rule out Klinefelter syndrome, and also we have to test for Y chromosome microdeletions. So if the testosterone level is reduced and also FSH is also reduced, it indicates there is an issue with the hypothalamus and pituitary. Mainly it is the central cause. So if it is a central cause, then we have to, if it is associated with hypothalamus or pituitary, definitely do a prolactin hormone analysis, because if there is any pituitary microadenoma secreting prolactin or macroadenoma prolactinomas, they are also known to cause severe oats or azoospermia in males. So we have to screen for other endocrinopathies, and we have to do a CT scan to rule out any tumors in the pituitary or prolactin. So if the testosterone is also normal, FSH is also normal, then it indicates it is an obstructive case. So along with FSH, we check LH also. So if there is an obstructive azoospermia, do a transrectal ultrasound and then check for any obstruction is there, or it is the absence of vas deferens. So if it is a duct proximal to the, usually the ducts proximal to the obstructions are dilated. So in this image, you can, as I already explained, so if it's FSH is high, LH is high, testosterone is less, it indicates it is a testicular failure. Example, Klinefelter syndrome. If the FSH is less, LH is less, testosterone is also less, it indicates hypothalamic causes. Example, Kalman syndrome. So in the semen analysis, you can get if there is any azoospermia, there is no sperm, if low volume ejaculate, or if it is an acidic pH, or if there is any absence of fructose. So what happens if it is azoospermia? There is no sperms found. Low volume ejaculate, if it is there, then we have to check. Majority of the semen volume is by seminal vesicles. So if the volume is less, it indicates there may be some problem in the seminal vesicles. So if the pH is acidic, it indicates the alkaline seminal vesicles are not secreting properly, because seminal vesicle secretions are alkaline pH. And also if there is an absence of fructose, it indicates the seminal vesicles are not secreting the semen, because fructose is secreted in the seminal vesicles. So if there is an absence of fructose, it indicates there is a problem in the seminal vesicles. So if these parameters are found out, it may be a ejaculatory duct obstruction, or it may be a congenital bilateral absence of vas deferens, or there may be a retrograde ejaculation. So we have to do a physical examination. So in the physical examination, if you are not able to palpate the vas deferens, it indicates it is a congenital absence of vas deferens. And also do an ultrasound scan and see whether seminal vesicles are dilated. So if the seminal vesicles are dilated, it indicates it is a ejaculatory duct obstruction. Or if the seminal vesicles are absent, it indicates it may be a congenital bilateral absence of vas deferens. So, and also do a semen analysis. And also after the semen sample is collected, take the urine sample and check whether sperms are found or not. So to check for any retrograde ejaculation. This is how we are going to evaluate it depending upon the abnormal semen reports. So doctors, is it too confusing? So I just put it in the flowchart so that it will be very useful for you. Okay, I'll proceed with a few things. Next. So if there is any retrograde ejaculation, the preparation, we do certain preparation, we alkalinize the urine. So before taking the semen sample, so for few days we have to alkalinize it before taking the semen sample. After they give the semen, ejaculate the sample, then we will collect the urine and then we will do the examination. I'm just skipping this part because it will be too much for you people. Then if you will do the ultrasound scan, mainly transrectal ultrasound to evaluate the prostate and seminal vesicles. So indications are low volume. Whenever there is a low volume semen, if the in the semen, if there is a fructose is absent, and also for diagnosis of ejaculatory duct obstructions. The others are scrotal ultrasound. We have to evaluate the testis, the vas deferens, and also diagnosis of varicocele like scrotal USG with Dopplers, and also the presence of 3 or more veins with we have, like, when we do the ultrasound scan, we can grade the varicocele depending upon whether they are visible, what is the diameter of the veins in ultrasound, so whether they increase with Valsalva or there is a reversal of flow. So I'm just skipping that part because it will be too much for you. And also, other option which are available is testicular biopsy. This we do it for obstructive or not, to differentiate obstructive or non-obstructive azoospermias. So it may be a diagnostic purpose also. And sometimes we do a testicular biopsy and freeze the semen sample. Whatever the sperm we get, we freeze that. That is called as therapeutic biopsy. These are done at the time of egg collections or as a trial before the egg collection. The retrieved sperms can be cryopreserved. When we do a testicular biopsy, we can get a report as hypospermatogenesis. There may be a maturation arrest or Sertoli cell only syndrome. So, and also these are the 3 reports which can come. So depending upon the report, we'll decide what treatment we have to give that couple. Next comes the genetic testing. In the genetic testing, we do the karyotyping, Y chromosome microdeletions, and also cystic fibrosis genetic screening panel. So these are done whenever there is a severe oligoasthenospermia, non-obstructive azoospermia, and any if the clinical features are suggestive of any genetic disease, then we will go ahead. Klinefelter syndrome is also most commonest among the chromosomal abnormalities causing male infertility. Klinefelter syndrome, that is presence of one extra X chromosome. So, and also the other things which are responsible are Robertsonian balance translocation between chromosome 13 and 14, which causes severe oligospermia. So all of you, as you are aware of Klinefelter syndrome, only 25% have the classical features of gynecomastia and tall stature. So among the infertile men with syndrome, the classical findings are small firm testes. So there is an elevated FSH. So low testosterone level, elevated E2 value. So it is mainly a condition of hypergonadotrophic hypogonadism. They have 47, that is 47XXY, that is presence of one extra X chromosome, which causes this syndrome. And also the other thing, next thing, what we check for is there any deletion in the Y chromosome? Microdeletions are there. In the Y chromosome, is there any deletion of certain areas like AZF, A, B, and C are the 3 important areas. If there is any deletions in these areas, they can affect the sperm synthesis. They can cause oligospermia and azoospermia. So in this, if you see AZF, A, B, and C, if there is any deletion in the A, if the deletion in the A region, it is very severe. So here the spermatogenesis is not going to happen properly, and also we cannot retrieve the sperm. And also in the B also, moderately we can get, in very few cases we can get the sperms, but the chances of not obtaining is also very high if there is a deletion in the B region. If there is any deletion in the C region, it has a very good outcome. We will get good sperms when we do the surgical sperm retrieval. So genetic testing for CFTR gene mutation, that is cystic fibrosis transmembrane ductus conductance regulator gene. So these are done whenever there is a obstructive azoospermia. Because if there is any partial or total absence of vas deferens, epididymis or seminal vesicles, or any unexplained congenital epididymal obstruction should be tested. So more than 800 mutations have been discovered. Routine screening of 32 mutations, 80% of the patients have these mutations. They are associated with renal anomalies. The autosomal recessive disorders, hence the female partner should be screened for carrier status. Azoospermia, it is a complete absence of sperm in the ejaculate. It occurs in 8% of the infertile men. So true azoospermia can be confirmed. So suppose if you have done the semen analysis in the one report, it has shown the azoospermia. Don't label them as azoospermia. Repeat the semen test after an interval of 4 to 6 weeks, and then see if the two values shows azoospermia, then only we have to label them as azoospermia. So then we have to, like, even if the sperms are not found, we'll centrifuge the semen sample and check for the pellet if any sperms, very few sperms are seen or not. So if sperms are seen, we call it as cryptozoospermia. Once azoospermia is diagnosed, it is imperative to differentiate whether it is an obstructive or non-obstructive cause. So typically the obstructive azoospermia patient will have a normal FSH, normal testosterone and normal testicular size. Whereas if there is a obstruction may occur at any levels in the seminiferous tubule or in the retate testis or in the epididymis or in the vas deferens or ejaculatory duct. So in non-obstructive azoospermia, usually they are soft and small testicles. They'll have elevated FSH levels. So there will, and also abnormal biopsy findings may be found, like maturation arrest, severe hypospermatogenesis, or germ cell aplasia. So like this, we can see the features in non-obstructive azoospermia. So this is a simple thing. When you do a semen analysis, in short, if the volume is less, it should arouse suspicion of one is patient has not collected properly, or there may be ejaculatory duct obstruction, or there may be a seminal vesicle agenesis, or there may be a retrograde ejaculations. So this is how you have to keep it in mind when the volume is less. So when you do a semen analysis, so if the semen volume is less than 1 ml and if the pH is less than 7, it indicates it is a obstructive azoospermia. Whereas if the volume is more than 1 ml and the pH is more than 7, it indicates non-obstructive azoospermia. So if it is a very severe, now I've explained till now how we are going to evaluate the male factor infertility. In short, I'm going to explain the treatment part. So if it is a very severe abnormality like azoospermia or severe oats, what we do is we do a small surgical procedure. We try to take the sperm directly from the epididymis. This is called as PISA procedure, that is percutaneous epididymal sperm aspiration. From the epididymis, if we take, it is called as PISA. From the testis, if we take, it is called as TISA. And also if we do a microsurgery and then extract the sperm, it is called as TESE. And also one more procedure is called as under microscope guidance. If we aspirate the sperms, it is called as MISA. So usually we do the PESA procedures and TESA. This micro TISA is very rarely we do the TESE procedures. So with these two only we get a good results. Till now we are getting good results. So TISA is testicular sperm aspiration. TESE is testicular sperm extraction. PISA is percutaneous epididymal sperm aspiration. MISA is microsurgical epididymal sperm aspiration. So, and also with this surgically retrieved sperms, we cannot do IUI. So we have to go for ICSI. So we have to do a IVF and then we have to do a ICSI. So this is about severe. Suppose if it is a mild semen abnormalities, how we are going to treat it. So one is if there is any severe lifestyle factor changes. So if change their lifestyle, if it is abnormal, reduce smoking, reduce drinking, then take a good nutritious diet which is rich in vitamin C like lemon, gooseberries, everything. Reduce the mobile exposures, avoid tight jean span, avoid tight undergarments. These are the lifestyle changes first we have to advise when the couple come with male factor infertility. Lifestyle modification is the first thing, and then prescribe them the antioxidants. So if the sugar is, if there is any systemic diseases, correct the systemic disease. And also if there is a mild factor like mild reduction in motility, mild reduction in morphology, lifestyle factors with antioxidants, definitely they're going to help. So with that minute changes, with giving all lifestyle changes, antioxidants, then we can do a simple procedure called IUI. If it is a very severe male factor abnormality, we go for IVF directly. If it is a mild factors, we can do the IUI procedures. So there are different ways to prepare the semen sample like swim up and density gradient. So the final prepared sample, if the sperm concentration is more than 10 million and also morphology around 4%, they are that gives a very good success rate in IUI. So these are the different 7 parameter techniques. So if you see, like when we have to do IUI, when we have to go for IVF FSC, IUI is done in mild male factor infertility if there is any retrograde ejaculation, or if there is any sexual dysfunction like impotence, ejaculatory dysfunction, unexplained infertility, or cervical factor infertility. IVF, we have to go directly whenever there is a tubal factor infertility, severe male factor infertility, treatment failures like many cycles of TI, at least 3 to 4 cycles, 3 to 6 cycles of IUI has failed, or in unexplained infertility after many cycles, 3 to 6 cycles of IUI has failed. So, and also whenever there is a severe genetic disease which requires embryo biopsy, then we have to do IVF with pre-implantation genetic diagnosis. So I'll just discuss a few 2 or 3 cases. It takes 5-10 minutes. So the case 1. So in this, this couple the case presented here is of a 49-year-old male referred to the Department of Urology for IVF clinic in a hospital. His female partner was 42-year-old with arcuate uterus with presence of fibroid. They have been married for 15 years. The chief complaint was secondary infertility with chronic husband had left chronic orcalgia assessed by the IVF physician. On examination, the volume of both the testes was normal. There is no hydrocele or varicocele. There was pain and tenderness in the left epididymis. So laboratory, it is mainly secondary infertility, not primary infertility. Laboratory analysis showed a sperm count of 11 million, sperm concentration of 11 million. Motility is 0%. Morphology, there is no morphology, could not be assessed, very bad sperms, and vitality was 0%. So the clinical diagnosis was the andrologist diagnosed the presence of epididymitis, and patient was placed on a course of antibiotic and antioxidants. Patient was prescribed doxycycline for 2 weeks and also like certain antioxidants therapies. So later on, the sperm parameters and all increased. So few things we have to analyze and treat it. So another case, 24-year-old patient N was referred to the infertility clinic because of primary infertility of 2 years of duration. 4 years prior to his admission, bladder neck fibrosis has been diagnosed, and he had undergone combined transurethral and open resection. So following this operation, patient lost his ability to ejaculate. Although erective ability remained unchanged, the sensation of orgasm occurred normally. The laboratory analysis showed the diagnosis of retrograde ejaculation was confirmed by demonstration of spermatozoa in the postcoital urine semen sample. The repeated postcoital urine analysis was performed according to the technique prescribed above and revealed a fair amount of spermatozoa, usually 18 to 20 ml of urine. Motility was repeatedly poor. Since the pH of the urine specimen ranged between 5 to 6, the impression of retrograde ejaculation with dry orgasm was there, and patient underwent Dixie cycle. So here, like in this, the patient had underwent transurethral and open resection of this bladder neck fibrosis was there. Surgery was done. Because of the surgery, the patient landed up with retrograde ejaculation. So whenever there is a problem, always keep in mind the retrograde ejaculation. So, and also one more case here, 39-year-old male who was childless after 8 years of marriage was diagnosed with azoospermia. Thorough medical evaluation, including testicular biopsy, was done. He did not have any abnormal findings on biochemical evaluation and other risk factors or evidence of congenital azoospermia. He has been working in a non-destructing testing NDT facility from 2005 to 2013, attaching and arranging gamma ray films on the structures and inner space of the ship. The patient's TLD counting they will do, that is thermoluminescent dosimeter batch recorded an exposure level of 0.01781 gyre for 18 months. Whereas the result of a fluorescence in fish translocation assay showed an exposure level of 1.9 gyre units of radiation, which was sufficient to cause azoospermia. Thus, we concluded that this azoospermia was caused by occupational radiation exposure. So here, especially when the male partner is working where the radiations are more, sometimes this TLD batch may not give the proper report. Then we have to do for the fish translocation analysis, check exact exposure, And then if the exposure is too much, then he has to be shifted to a non-radiation exposure jobs. So the semen analysis showed azoospermia in 2 semen samples. FSH level was 19 and LH level was 5.5 and testosterone was 2.5. Genetic study showed normal karyotyping without Y chromosome microdeletion. So azoospermia with certainly only cell syndrome was diagnosed. Thus, testicular biopsy was performed to determine the cause of azoospermia, and he was diagnosed with Sertoli cell only syndrome caused by occupational radiation exposure. So it should be like we should be very cautious. Like whenever they come, we have to take the proper history about the occupation. That's why I've added this case. So another case was like our 37-year-old male married for 8 years with cohabitation of 7 years and presented to the infertility clinic for tertiary care center. The individual was on regular medications for generalized tonic-clonic seizure for the past 3 years and recently diagnosed to have a type 2 diabetes. The systemic and genital examination and ultrasound of the scrotum were essentially normal. His hematological and basic biological parameters were normal. All viral markers are negative. Repeated semen analysis on the 3 separate occasions revealed azoospermia. Hormonal profile revealed elevated gonadotropins, that is FSH-LH was high and testosterone level was less. So the impression was azoospermia, which was a non-obstructive cause. The present study reports of the clinical, hormonal, and cytological profile of the male patient with azoospermia was a carrier of an unknown Robertsonian locations involving small acrocentric chromosome of 21 and 22. So karyotyping showed there was a Robertsonian translocation which has resulted in azoospermia. So that's why role of hormonal evaluation, that is FSH, LH, testosterone, karyotyping, everything is important. Even testicular biopsy is important whenever you are evaluating the azoospermia cases. Here you can see the translocations. Here between chromosome 21 and 22, you can see there is a Robertsonian translocation. That's why it has caused azoospermia. So these are about 4 cases. So dear doctors, do you have any questions?
Thank you, Dr. Maheshwari ma'am, for your wonderful and informative session. We can take up the question and answer session now. Dear doctors, any questions? Please unmute yourself and ask the question. Doctors, you can find questions on your screen. You can answer them. And we'll just look into the correct answers shortly.
The evaluation has to be done within 6 months of married life in. So 75% of the people have opted for all of the above, and that's the correct answer. Congratulations. We'll go to the next question. The hormonal profiles in hypogonadotropic hypogonadism is all of the above except low FSH, low E2, low LH, high AMH. 70% of people feel it is high AMH, and that's the correct answer. Good. Evidence of ovulation are free fluid in the POD, reduction of the size of the follicle, high P4, all of the above. Yes, 80% of the people feel all of the above is the right answer. Yes, you are all right. You are all really alert and you are really listening to the lecture. Very good. Ovarian reserve tests, highest sensitivity is with FSH, LH, E2 estimation, clomiphene citrate challenge test, AFC and AMH, none of the above. Yes, you're all right. AFC and AMH has the highest sensitivity for the ovarian reserve test. Very good. Awesome. The best method to evaluate the fallopian tubes is CPT on laparoscopy, sonohysterography, fluorohysteroscopy, hysterosalpingography. There's a tie between CPT and hysterosalpingography, but actual answer is A, CPT on laparoscopy. Chromoperturbation is the gold standard.
following diseases causes ejaculatory dysfunction except multiple sclerosis, diabetes mellitus, spinal cord injury, sexually transmitted disease? Yes, that's correct. It is sexually transmitted disease. So, all of the following drugs causes male infertility except, yeah, that's correct. It is L-arginine.
Spironolactone and anabolic steroids causes infertility, doctors. That's not the answer. It's L-arginine.
According to new WHO to 2021 sixth edition, normal sperm count per ml is 20 millions per ml, 16 millions per ml, 15 millions per ml.
WHO 2021 is 16 million.
16 millions per ml.
Yeah.
What is aspermia? Options: abnormal morphology, absence of sperm in semen, absence of semen, or 75% dead sperm in semen. That's correct. Absence of semen. Low volume of semen is due to all except all incomplete collection, ejaculatory duct observation, seminal vesicle agenesis, or varicocele.
It's ejaculatory duct obstruction. And it is not all incomplete. It is just incomplete collection.
It is option D, varicocele. Here we come to an end of question and answer session. Dear doctors, do you have any other doubts? Dr. Maheshwari ma'am, you have a question. Drugs used for delayed liquefaction of semen.
Hello.
Yes, ma'am. We are able to hear you, ma'am.
So one is like if there is any problem, if the semen is very thick, so we will check what is the causes because of any problem with the glands. So in the laboratory, we will check in the first semen sample only, we will not give any other medication. In the second sample only, like if we see whether any high viscosity is there or not. Majority of the times for high viscosity per se, we will not any prescribe any other medication. If it is associated with any other abnormality, then we will add.
Okay. Dr. Anupama Shetty, I hope your question is answered. For Dr. Asha, one question we have, ma'am. How many cycles of IUI is permissible?
Yeah, it depends on the married life, age of the couple. There is nothing called blanket permission for IUIs. We have to be extra cautious. More than 4, you have to be very careful whether to do more. But according to the textbooks, 4 to 6 is permissible.
Any other questions, dear audiences? You can unmute yourself or post the question in chat box.
Maximum duration of antioxidant therapy for men. Yes, doctor.
So usually we give it for minimum 3 months, which lifestyle modification is prescribed. So usually we tell after starting the antioxidants, 4 to 6 weeks after starting it, at least to repeat the semen analysis to decide to how long we have to continue. At least a 3 months course has to be advised.
Ma'am, we have one more question, ma'am. What is the prognosis if there is a mild bleeding during IUI procedure?
If the bleeding is from the cervical erosion and you have crossed it with your IUI catheter, not much impact. But you have touched the endometrial cavity and the bleeding happens from the cavity, there will be compromise on your result. Definitely results will come down.
Thank you, ma'am.
What do you prefer, Alice or Sims? We prefer Cuscos. If not improving after 3 months, how long we can continue? Max 6. Thank you all doctors for your very highly interactive sessions. And we appreciate if you can log in month after month for this continuous CME programs. We have very good topics lined up for you. Thank you for participation. Thank you, Dr. Maheshwari, for that wonderful session. Thank you, Ulfa.
Thank you all the participants. And thank you creative teams and BD teams of GGIRHR. Stay safe, stay healthy.
On 27th September, very, very important topics of assessment of ovarian reserve and the very highly requested topic of drugs used for ovulation induction. Please log in. Thank you, everybody.